So, today we are going to learn about some general guidelines, or they are not actually the principles, but they are sort of a guidelines for repertorization. When we are to repertorize any case, so what are the things you should keep in mind with any method or with any type of case. Okay. So, these are some 8 to 10 points we will discuss. Okay. So, they are not rules, keep in mind, but they are sort of guidance. The first is about analysis. Repertorization without analysis. Analysis means case analysis. When you don't analyze your case or symptoms, then that type of repertorization is numerical or mechanical repertorization, and you will not have qualitative aspect in your totality or repertorization, but it will just a mechanical or mathematical type of repertorization. So, it is not good or bad, it is not like that, but just imagine if you are having any case, a regular type of case with a regular type of symptoms, then without analysis you are either ending up repertorizing all of the symptoms, or you are ending up with repertorization with the selected rubrics of your own choice without analysis. That is of no not a very standard or qualitative aspect of totality. So, somehow it will either lead you to a confusion with a lot of medicine covering all the symptoms, and you are not able to pick up a small group of medicine from repertorization, or without analysis you are not having clarity about which symptom are important and which are not, but you are randomly picking up what you feel is important or not, and that repertorization or that group of medicine will again not lead you to the right remedy in regular cases. Okay. So, this is one point. So, the case analysis of the symptoms of the case before repertorization is almost necessary for every case at a learning level or at a fresher level. Okay. After some years you will get a skill that the analysis happens, but very quickly without theoretically mentioning all the symptoms, but the process remains the same. Okay. So, by analysis you are having totality with selective symptom and not the all symptom. So, this is sort of a mechanical versus selective or mechanical versus artistic style of repertorization. When you do analysis, you are now clear that these symptoms are more important than those, then your totality becomes a clear one, and now based on that totality your repertorization will give you a group of medicine which is worth to consider for a selection of remedy. Okay. So, this is one thing. Another point is, so you need to remember in any type of method or any type of case, certain things does not change for analysis or importance. So, you need to give importance to your symptom or rubric in your totality. So, you will give importance based on what? Based on, actually you can give importance based on the approach you select, either following Kent method or Boger. But in any method, whatever method you pick up, some things, some points remains the same. For example, causation remains almost most important in every type of cases. Okay. Then modalities are also important in almost every type of cases. In modality, aggravation is more highlighted mostly than amelioration. In aggravation or amelioration also, if you are having a mental modality and physical modality, right, patient is aggravated by fear or fright, this is modality, but a mental modality, and patient is aggravated from milk. So, it is very clear that the mental modality is more important than physical one. Okay. Whatever may be the case, either Boenninghausen or Kent or whatsoever. Okay. So, it is not always the fixed format, right, if you are following Kent's method. So, mental general, physical general and particular, okay. But what if you are having a modality of mental modality, then it comes first, even in Kent method and Boenninghausen method also. Okay. Now this and then comes physical generals in particular. So causation is most important, modalities are more important than sensation, mental is more important than physical, and general is more important than particulars. These are sort of general things you should remember in every type of repertorization. Okay. But now this sort of rules you don't need to apply blindly in your case, because actually you need to give importance according to the context of your case. Okay. So suppose you are handling any chronic case. Okay. So you are having a lot of symptoms, mental symptoms, physical symptoms, and also causation at some point of time for some event or for some particular complaint. So that is a causation for that one complaint. So it may not be that much important in relation with the whole case. But if you are handling acute, then the exciting cause becomes most important. But exciting cause for particular complaints is not that much important while you are handling the whole chronic case with a lot of symptom and many of multiple complaints. So you need to give importance of either cause, modality, or whatever symptom according to your case also. So there are general rules, but those rules need to be applied in context with your case. What is important and how much it is important in your case. Okay. So mental is more important than physical. This is very clear and general commonsensical notion. But some mentals, you also know that in your case there are some mental symptoms, but they are not very well marked or they are vague. You are having a very strong physical general and definitive physical generals. Then that mental symptoms are not at that level important than physical generals. Though we know that mentals are more important than physical, but you need to apply that according to your case. Okay. Mentals are always important than physical, but they should be definitive, they should be well marked, and they should be well understood from different perspective. Then they are definitely more important than physical. Okay. But vague mentals will not help you. So you need to give importance according to some general norms and also with your case. So you need to give context to your from your case to the importance you are giving to each symptom. Okay. So it is not a blind rule that you first put down ailment from. So what's ailment from in my case? So context of your case is also important. Okay. Now comes the approach selection. Every case has a set of symptoms which may vary case to case. So they are expressing symptoms in a different way. Some cases are throwing mental generals, physical generals, in particulars, everything. So you may repertorize them with any method. Some cases are lacking in mental. Either mentals are not that much important in that case, or somehow you might not be able to get mentals from that case, whatever may be the scenario. But some case may not have that much amount of mental data or mental symptoms. Okay. So every case differs in symptomatology presented to you. Okay. So according to that you need to select the approach. Now what is approach? Approach is the way for a repertorization. Very common, or I am telling at a very primary level. You need to learn every approach in detail. Mainly three: Kent, Boenninghausen and Boger. So you just understand what type of case symptoms in your case, and based on that you select approach. If you are having mental generals in a very well qualified manner, physical generals, then the Kent approach is best. Your case is lacking in mental symptoms, but you are having a good modalities, then Boenninghausen approach suits that case very well, then Kent. Okay, you are having not that much of data in your case, but you are having a clear understanding of pathology and pathogenesis of that phenomena or disease with some peculiar aspect of a disease, then Boger may help you, then Kent and Boenninghausen. So approach selection helps you to get a better outcome in terms of group of medicine. How? Because every case needs a different way to work it out, because they represents in terms of symptomatology differently. Some cases may be worked out with any approach because they are well rounded and good in symptoms of every type. So you are having very well number of cases symptoms, so you can work out with Boenninghausen also and Kent also. Okay, so approach matters before repertorization, because your repertorization is actually based on that particular approach, which type of symptoms you are selecting, which type of generalization process you are adopting in that particular repertorization, whether you should generalize those particular symptoms or not. Okay, which type of totality, your totality should contain how many rubrics, this all be decided by your approach selection. Okay, so if you are generalizing from particular to general like Boenninghausen, so it's a different scenario. In Kent you may not generalize that much casually from particular to direct general, so you need to have that particular sensation or modality in more than two locations. Okay, in Boger you are generalizing pathology and making pathological general. So these are different approaches that is actually based on case analysis of your case, and that approach decides the quality of repertorization. Okay, then comes the selection of repertory. So we mostly use modern repertory either in form of synthesis or any modern repertory, complete repertory. So they are having a good collection of rubric and remedy. But as far as the student level, or we can say before you pick up a modern repertory, it matters actually which type of repertory you are selecting for your case. Okay, so we are keeping the discussion on modern repertory aside for now. Okay, but just consider the previous classical repertories. So it actually matters which repertory you select based on your approach. Okay, because the Boenninghausen's repertory is based on the principle of generalization, grand generalization, principle of complete symptom, importance of concomitant and modality. So the process you do before repertorization should be in line with that philosophy and structure of that repertory. Or Kent repertory is built in a different way than Boenninghausen. So if you are picking up Kent's method of repertorization, then Boenninghausen's repertory is not a good choice, but a Kent's repertory is a good choice, because Kent repertory is presenting a good number of mentals and your totality contains a good number of mentals. So repertory should be in line with the type of totality of your case. Okay, so you need to understand the whole connection of your case analysis, type of symptoms you have, totality you make on that particular approach, and the selection of repertory. Okay, because just imagine Boger's totality, you are having any pathological case, you are picking up some tissue affinity and pathological general. So there would not be too many numbers of rubrics in your totality, but very essential rubric, and you just repertorize with the compatible repertory, either Fatak or Boger synoptic key, and you will have a clear idea of remedy. So selection of repertory, it matters in this way. Also, we look at this point, selection of repertory, from another angle. The repertory you select for repertorization, your method to repertorize, your style to form the totality differs. If you are to repertorize from Phatak's repertory, then the method is different from if you are to repertorize from Kent or BBCR, because they both are different in structure as well as philosophy. Okay, understood. Now talking about rubric hunting. Okay, since final year we are obsessed with hunting of rubric, right? It is a good practice to do, but sometimes in certain cases certain symptoms you may not find in repertory, even from in materia medica. So I would tell you, try to hunt or try to find almost every symptom into rubric, but you need to know some symptoms are so that you may not find them in repertory. So don't be obsessed to hunt every symptom into rubric. For some very few symptom in your case you may not find rubrics, it's okay. So it is not necessary that you need to convert every symptom into rubric. Some are good symptoms, they are convertible easily into rubrics. Some are the symptoms that will pose you a difficulty for conversion, so try to skill up yourself for that conversion. And some are the symptoms that you may not find in rubric. Okay, so you don't be obsessed to hunt for rubric for each and every symptom or each strange symptom. You need to understand repertory is a list of symptom or rubrics made from materia medica and also clinical experience. So some type of phenomena or some type of understanding you get from your case, that is convertible to rubrics, but in certain cases it may not be. That's okay. But if you feel that aspect of your case is important, write it down in your terms. It will help you to select a medicine afterward, after repertorization. So it is also important that you understand some aspect, you don't get appropriate rubric from the repertory, but you feel that it is very important in my case. So you write it down, it is a part of your totality, but not the part of repertorization, but it will help you to select a remedy after repertorization, because you understand the patient through that aspect or that particular symptom. Okay. And know which type of rubrics you are taking for repertorization. It is not necessarily just the similarity that a symptom, this is the rubric. No, just try to look which type of rubric it is. It is general rubric or particular rubric. How many remedies it contains. If they contains a too large number of remedy, or it may contain a very less number of remedy, 1, 2, 3 or 5. So those type of largest or smallest rubrics may not help you to get a sensible group of medicine in a repertorization process, because the role or job of repertorization is to have a group of medicine by narrowing it down. And if you are taking 10 symptoms containing almost 500, 600, 400 remedies, so you will get a long list of remedies which contains almost every rubrics of your case. So it will not help you to have a small group of medicine to consider after repertorization. And if you take small rubrics which contains 1 remedy, 5 medicine, 4 medicine, 7 medicine, that will also not give you a consistency. Okay. So one remedy covers this, other remedy covers this, because they are very less in number. So try to understand which type of rubric you are taking, how many medicine it contains, you are taking general rubric or particular rubric, and try to connect it with the approach or method you have selected for your repertorization. Okay. Now another point is less coverage and some of less proven remedy. In some instances, most of the cases will give you main well proven medicines or well known medicine in repertorization, but sometimes in first few medicine you will get some rare medicine or less proven medicine, but that may not cover every symptom, or that may not cover every symptom with a higher grade. Okay, still you need to consider that remedy seriously. Why? Because it is not well proven, so it is not available in a larger number of literature. That's why it is also not well verified. So the presentation in terms of gradation of that remedy in repertory is less, almost 1 mark, because it is less verified. Okay, but you need to give a thought, at least don't select directly. But my point is, those remedy which are coming afterwards or lately proven, so you may not find those remedy in older repertories, or even in modern repertories. The gradation might not be that much higher, because for that you need to have a lot of data. But by a clinical experience of different homeopaths, or clinical experience, or the materia medica based on that clinical experience suggest you to the different aspect by which you can select that remedy. Okay, say for example, if you are repertorizing with Kent or BBCR, you may not have a carcinosin. Okay, in modern also carcinosin is present, but the point is, some remedies are not well presented in repertories, so you may miss that. But when it is coming into the picture, so you need to consider that for differentiation, and don't differentiate only on the basis of numbers. Okay, give a look at a materia medica level. Another is, don't underestimate the differentiation. So don't try to give remedy only on the basis of repertory sheet. When you repertorize, you are feeling first is arnica, second is naxomica, third is natramure. I would like to give arnica because it contains all the rubric and having a more total number than second or third. So don't underestimate differentiation, because actually now the qualitative aspect comes. Repertory is a sort of a quantitative aspect, definitely based on the quality of your rubrics, but ultimately it does a mechanical job of calculation in repertory. Okay, so now comes the differentiation, and differentiation is based on many factors. Now comes your understanding of your case, which you may not be able to translate into rubrics while analyzing the case, and that might be the very well important point for the whole perception of your case. You took a whole case, you get some idea of patient, but you are not able to translate that into rubric. Which type of patient is this? Or you may translate into some words, but not the rubric. So that understanding is very crucial to select a medicine, because that is of the core of patient. You perceive the core of patient not in terms of rubrics, but in terms of understanding, and that may not be translated into rubrics in some instances or sometimes. So it is very important that you give appropriate importance to the process of differentiation. So it is not just the theoretical job, or you just differentiate on the basis of hot and chilly only. No, you also differentiate according to what is your perception of your patient in terms of personality or personality image of what type of person he or she is. You also differentiate on the basis of pathological process you are having in your case. You also differentiate on the basis of tissue affinity or sphere of action, because sometimes it is very confusing. Two medicine are going hand in hand and you are confused, but one medicine covers the sphere of action of your case and one medicine not, then it also becomes the important point for differentiation. It is not always the hot or chilly, it is also important, but there are many factors to consider at the level of differentiation. So my point is, the job to select a remedy is not finished after repertorization. The point of differentiation is yet to do, and it is also a very important point. Okay, so don't underestimate that differentiation point. And another thing is, you need to repertorize almost every case at your level, because it will give you a habit to repertorize, habit to analyze your case. It will give you a practice how to use repertory. But after some study or some experience of cases, you will have a clear idea which medicine you need to give after case taking. So medicine is clear, totally clear after the case, and you are confident enough based on your knowledge of your case in materia medica. So in that case, the repertorization sometimes may not help. Why? Mostly it happens that when you are clear with the medicine after a case, you repertorize the case, it gives you same remedy. It may happen. This is one thing, it will give you confidence. But try to understand, in certain type of situation or certain type of cases, the whole case taking process happens in a different way than other case. Your phenomena of case taking or case receiving goes in such a direction that you understand the whole patient, and the focus is on understanding patient rather than collecting a symptom. So in terms of symptomatology, you are not clear, you are not having a list of symptom to properly analyze or to properly repertorize also, but you are confident enough. These are the things happen to patient, and my understanding of patient is this, that this patient is of this personality, of this remedy. As your case didn't go in a symptomatic way for that particular situation I am talking about, so repertorizing that case will not lead you the same remedy you perceived to be given. Okay, so it is not necessary to repertorize when you are clear with the remedy. Okay, so sometimes it helps, but sometimes it may confuse you. So I am not talking that you don't repertorize when you are having any particular medicine in mind, but you are confident enough about your selection of medicine, then go read materia medica and select. You are confident enough that my patient is from this or this or this medicine, so read materia medica and decide which medicine you need to give. So repertory in that case don't come in the picture. Okay, so sometimes repertory may confuse if you are not having a clear idea of symptoms in your case and you perceived your case in a different way, which may not help the process of repertorization. So it is not necessarily that you need to repertorize every case when you are having a clear idea of the medicine, but it is not happening at a very initial level. So you actually, by norms, you should repertorize every case for now. But after some time, just remember that if you are clear enough, confirm the remedy from materia medica, differentiate it and give it. Okay, so these were the point which I feel you need to keep in mind about the repertorization, whichever method or whichever repertory you are using. And I hope it may help you to get a better process of repertorization and better success in your repertorizing process. Okay, thank you.